Good afternoon and welcome to Science Says. Thank you so much for being here. It's a total delight to see everyone and have everyone join in our community today. Science Says is a terrific opportunity for people to know what's happening at the Hutch, some of the great science that's happening, some of the wonderful work our people are doing. I want to start off by just saying that there are two events that start today. The first is that it's Lunar New Year, which is very important to so many members of our Seattle community. And the second, it's the first day of Black History Month, which is also important to many members of our Seattle community. So thank you for recognizing the importance of these events to the people at the Hutch and people in our community. If you came to November's Science Says, you saw videos of Trevor Noah, host of The Daily Show, who was interviewing some of our scientists. And I'm excited to announce that Trevor's coming back, Science Says, on Tuesday, March 22nd. And this time, he's joining us live. So we're very much looking forward to that. Please mark your calendar for 9 a.m. Pacific Daylight Time and sign up to attend. So we're going to have a great conversation today. I want to just remind everybody about the Q&A. Please feel free to ask questions. Much of what we're going to do today is dependent upon having great questions in the question queue. So please use the question and answer toggle on the side. We will look at all of these and collate them and try to answer as many as we can during the course of today's discussion. So I don't need to tell you how tough the last few years have been. We've all been living it. At a recent Fred Hutch Town Hall, the most upvoted comment, upvoted by nearly 300 people, was the comment, "I'm exhausted." People are tired. People are done with this pandemic, even though the pandemic is not necessarily done with us at this point. We've all been processing new information, balancing risks, trying to decide what can we do, what can't we do, how do we see our loved ones, how do we negotiate the world, which is so different now than it was pre-pandemic at this point. And, you know, I think when I think about the place of the Hutch right now, last year I thought about the importance of resilience and how critical it was for us to be resilient and committed to the year. My hope is we're moving from a time of resilience to a time where renewal is possible, and we can talk about what it's like to move on and to start renewing our commitment to the values and the mission of our work, of our families, of our lives. We're going to hear from a panel of experts today in diet, nutrition, and smoking, and how these factors affect the rest of cancer and recurrence, and how so many people have been struggling with their own personal issues during the time of the pandemic. How do we sort of get to the next step? The scientists you'll hear from today are some of the most experienced cancer prevention researchers in the world, and between them, they've led scores of studies and published hundreds of papers. After the panel discussion, we're going to have a COVID corner with Dr. Catherine Liu, who's been a stalwart of our pandemic response at the Fred Hutch, at the University of Washington, and at Seattle Cancer Care Alliance. And we'll, of course, try to answer as many questions as we have during the pandemic. So next, I'd like to welcome our first three panelists. Let's bring them on. First is Dr. Jonathan Bricker. Jonathan is a clinical psychologist who develops technology-based tools that help people change behaviors that affect health. His tools to help people quit smoking, including mobile apps, chatbots, websites, and phone counseling, are the principles of acceptance and commitment therapy, known as ACT. He's now expanded this model to target other health behaviors. After a successful donor-funded pilot project, he received a $3.7 million NIH award to lead a large randomized controlled weight loss study. Jonathan, great to have you here today. Next is Dr. Ann McTiernan. She's a physician, researcher, and author, including the author of 2 memoirs. She studies whether exercise and other lifestyle changes can prevent cancer and cancer recurrence. He leads and co-leads many trials, including the ACE trial, which aims to learn whether physical activity can prevent breast cancer. He helped develop the federal government's 2018 physical activity guidelines for Americans and has served on many other national and international health advisory boards and working groups. Welcome, and welcome to our discussion today. And finally, I'd like to introduce Dr. Marian Neuhouser. Marian leads our cancer prevention program, both at the Fred Hutch and within our comprehensive cancer grant. This is one of the top programs in the United States, and the first one funded by the National Cancer Institute. She studies the role of nutrition in cancer prevention and survivorship with a focus on breast and prostate cancers. She's consistently among the top cited researchers in her field. She's led a half dozen studies, including the Eat Well study, which is comparing the biological effects of healthy diets with and without meat. She's working to improve methods scientists use to assess diet and physical activity, and she helped draft U.S. nutrition guidelines in 2015. She's past president of the American Society of Nutrition. Welcome, Marian, to this discussion. So we have an expert in smoking, an expert in exercise, and an expert in diet. You're probably all experts in all three of those things, but we're really delighted to have a panel, which I think is going to be great today. So I'd like to start with a question. So beyond screening and early detection, what are the most important actions we can take to reduce our cancer risk? And what do we know about other risk factors? And I say this because, we all know that it's important to get our pap smears and get our skin checks and have our colonoscopies done as part of our evaluation. But how do we think about other factors? And I guess, Ann, I'll throw that question to you first to get your impressions.
Sure. Well, thanks, and thanks for inviting me, and I'm so happy to be here today. I think in terms of prevention of something that can reduce your risk factor, kind of like wearing a seatbelt. And so while there's no guarantee, you can reduce your risk. There are things you can do. And we would talk today more about keeping weight under control, reducing smoking, avoiding smoking, eating the right diet, being physically active, but also being aware of what some carcinogens are. And some of them are really relevant to our time right now. We've been through a pandemic, and if anything was something that was a risk factor before, it may be magnified during this period. So we can touch on that as well. But things like, in addition to the screening that you mentioned, avoiding excess alcohol, keeping weight under control, being physically active, certainly avoiding smoking, and vaping is one of those as well. But some of these are going to be difficult, but some of these, and hopefully we can talk about that today, some of these can help us feel better and get through the pandemic, so you can get double benefit.
And I guess one question I'll ask you is, do you think during the pandemic that people drank more and let their weight get out of control? Was that an issue that you've observed? Is that something we just think about or read about? What did we find during the pandemic?
Well, I think maybe my colleagues have more data on this, but I think we're usually behind the curve in terms of getting information and getting data compiled to know exactly what's happened on a population level. But certainly you hear about anecdotes and you hear a little bit about more alcohol being used, more vaping. If something is a relief of stress in good times, it's going to be even more so in hard times. And so remember the baking pandemic? During pandemic, people started baking. Well, that's not necessarily a bad thing. But if they were eating excessive amounts of sweets or high carbohydrate food, they might have been gaining some weight there. So I think it's a little early to tell, but certainly people, if they're under stress, and Jonathan can talk about that more as a psychologist, if they're under stress, they're going to reach for things that they've reached for in the past. And some of those can be helpful and some of those are less helpful.
So I guess that's a great point and a great way to sort of put it in that perspective. What we do that makes us happy in good times, we do even more and possibly to excess in times of stress, which is terrific to think about. Next question I have is from Marian, and this is an interesting way to think about this. We were talking about this previously, which is I'm really bad at I make New Year's resolutions. I start a good diet and healthy eating every January. And by February, I'm still doing my best, but probably not as well as I was doing in January. What advice do you have for people to think about as they transition through the year? And do we focus on diet and dietary habits too much just in January and not the rest of the year?
Yeah, thanks, Tom, for that question. First of all, I would urge people not to give up. And I think there's a tendency when January comes around for people to make wholesale changes. They want to change everything. They want to change what they're eating. They want to change their exercise habits. A lot of people do dry January where they reduce or eliminate alcohol. And that can be a little bit overwhelming to try to make so many changes at once. So I would urge people to make small changes. Small changes are often more easily attained and maintained. So as an example, if someone typically has a mocha every day or a caramel macchiato, they could make a small change to a non-fat latte. And that right there eliminates about 400 calories per day. So that's a small change that's relatively easy to maintain. And if someone has a slip, that's fine. We know that today is Lunar New Year, as you mentioned in your welcome. There's lots of parties for many communities, lots of eating. We have the Super Bowl coming up in 2 weeks. Again, there's going to be parties and eating, hopefully in smaller groups. But I would urge people not to feel badly about those times. We know that eating is celebration, it's families, it's being together. So you can enjoy those times, enjoy it, and then think about small changes that are easy to start and maintain throughout the year.
That's great, Marian. And again, one of our focuses here is trying to think about how diet, exercise, and behaviors like smoking impact cancer. And so, Jonathan, we know that the cancer burden in the U.S. is disproportionate. We know that that communities of color, African American communities, Hispanic communities have high rates of cancer. Obviously, the cancers tend to be different. What can you tell us about how smoking, for example, hits different populations differently, and how we think about ways that we've made impact or not made an impact in smoking and cancer incidence across different communities in the U.S.?
Well, it's a great question, Tom. First thing I want to say is that during the pandemic, smoking rates have gone up. Tobacco use has increased for the first time in 20 years during the pandemic. So Americans are smoking more, and this has become an even more important public health problem. Simply the most preventable cause of premature death is to quit smoking. And in communities where that's disproportionately most affected is in Black adults and American Indians. And my lab has been addressing that disparity in two important ways. But first, let me just say why that's so important. See, Black adults, they are less likely to quit smoking. They're more likely to relapse. American Indians have the highest smoking rates in the country, and they have the lowest quit rates. And there are a lot of reasons, including discrimination and racism and lower access to proven treatments. So we just published 2 studies that viewers can access for free, where we recruited Black adults and American Indians all over the U.S. through social media. We even recruited people in rural areas and people on tribal lands. And we wanted to know if our app, our I Can Quit app, could help them quit smoking. And the good news is that both groups that we recruited were engaged with the app, they liked it, and the best part was they were almost twice as likely to quit smoking with the I Can Quit app as compared to a leading app. And so I think going forward, there's a lot to do in building partnerships with Black and American Indian communities and to help tailor the programs and help them get in people's hands. And that means you work with the community, you collaborate with them, you develop novel programs that are tailored, you do capacity buildings, and you involve them in the process. So that's where we're headed now in our lab to try to address these very critical health disparities.
Thanks, Jonathan. So, and I'm going to bring the next question to you. And, it comes down to exercise and cancer. So I have two questions about this. One is the role that exercise plays in cancer survivors. And the second is the role that exercise plays in preventing cancer. Is most of the benefit from exercise in helping people who've been diagnosed with cancer survive longer, or is it in helping preventing cancer? And what's your take on that?
Well, I think it's both, and the data look like it's both. So the cohort studies, including one that we've followed at Fred Hutchinson, but through around the world, the cohort studies where you recruit number of people with a cancer and follow them forward over time. If we ask them what kinds of exercise or what kinds of physical activity they're doing, we do see a trend that the people who are exercising more have better survival. Now, one of the issues with cancer survivors is that the data usually aren't detailed enough to let us know that, in fact, it is the exercise rather than something about the disease itself. So there are studies now that are trying to get more detailed, more granular information about the patients, about their treatments, to make sure that it's not the results are valid. But the data are looking promising. There have been clinical trials in cancer patients and survivors showing that an exercise program, even just as short as within 3 months, you can see improvements in quality of life, decreases in fatigue, improvements in sleep. These are all incredibly important for survivors. Some things we don't know is that when is it not safe? So any oncologist working with cancer patients knows that you have to look at adverse effects as well. Are there any patients for whom some kinds of activities are not safe? Somebody who's had a cardiotoxic drug, for example, something that's not safe for the heart, is it safe for them to exercise? So there are some studies ongoing there. But overall, the guidance is for people who've had a cancer to be physically active and follow the Surgeon General guidelines of about 150 minutes a week of moderate activity.
And that's
talk to your provider or your doctor or your nurse about what kinds of exercise are appropriate for you.
And that's one of my questions, Ann, is this issue of what do we need to be doing to exercise? The data is all over the place in the public consciousness, meaning some things say, I was reading one this past week, which said all you need to do is the 7-minute workout 3 times a week and you're fine. You just said 150 minutes of exercise. Other people have said it's a question of how high you raise your heart rate, for how long you raise it. And then yet you have people who are doing, they run in the morning, they run at night, and they lift weights at lunchtime. So the question is, what do you need to be doing? Is there a threshold amount you need, or does it keep getting better with the more exercise you do? Can you give us some guidance on that for our lives?
Well, for cancer prevention, we don't have much information on what happens at the lowest level of activity. There is some evidence from very large cohorts of people that even just getting up off the couch is helpful, and any little bit more that you can add is helpful in terms of prolonging lifespans, maybe in reducing cardiovascular disease. But for cancer, it really looks like you get more benefit with the more that you do. What we do know is that from looking at all the data, and we did this for when we worked on the U.S. Guidelines, when you look at all the data together, it really looks like that guidance of physical activity, 150 minutes a week. So that's about 30 minutes a day, 5 days a week. However you get it, moderate activity is just something like taking a walk, that reduces risk by about 10 to 20%. And that's pretty consistent across studies. You don't have to be an athlete. That's the good news. So there are some people, like you mentioned, that are lifting weights and running and competing in sports. But for most people, we don't think that way. We don't have the ability to do that. We may not have the time to do that. And the good news is you don't have to. Just being physically active in whatever way is you enjoy, and whatever way you can fit into your lifestyle is going to be helpful.
That's great. And so, Marian, I guess a question I have for you is similar to what I just asked Ann, which is how do we separate the noise regarding diet? I can't think of anything that's got more noise around it than what we should be eating and what constitutes a healthy diet. I know for one, whenever I have a meeting with our population health folks or a meeting with Garnet, I'm always nervous. I'm not going to be seen with the donut. I'm going to make sure that Garnet thinks all I'm doing is drinking orange juice with no added fructose, extra fructose corn syrup or anything like that. What is the how do people who are listening today make sense of the sources of getting good information on what our diet should be, both for cancer prevention and for overall health?
That's a great question. And I'm sure many of the people attending today are as confused as you are, and as many of the public is, because there is a lot of confusion out there. I think what I would recommend to the listeners today is to learn where was the study done and how was it funded. All of our research here at Fred Hutch is funded by the NIH, and that guarantees that it's rigorous, because you have to submit in your grant application a section on rigor. It's peer reviewed. The reviewers have to comment on how important the scientific question is, how it will fill a gap in nutrition science research, and how rigorous is it. So that's really important. The second is, where was the study published? We publish our work in peer-reviewed medical journals. So again, we have another layer of rigor applied to the research, where it's peer-reviewed, then the editor reviews it. So all along the way, we have several ways that our research is evaluated. And people ask really tough questions, both in grant reviews as well as when you submit a manuscript for publication. What viewers might listen to a lot or hear about is someone's podcast, a popular book, a blog, anything on social media. Those are people's opinions, but they're not science. So often they are people's testimonials about what might have worked for them, but that's not science. And so that's a way to separate what is science and what is someone's opinion or their own case history, but it's not science.
Thank you. And last question for Jonathan before we introduce Catherine. So Jonathan, many of the people who are joining us today are people who've been extremely generous to the Hutch and have been really important to supporting science at the Hutch. And can you just comment in your own work how gifts from philanthropic donors have enabled the work you do at the Hutch and have allowed your research to thrive?
Well, donors have made all the difference in my lab, Tom. I mean, they have provided the seed money for me to conduct pilot studies, and that helps me get a new idea started. And those pilot studies give me the critical data that is needed for those big grant applications that Marian was referring to, the ones we apply to that we depend on to support our labs here at the Fred Hutch and to conduct those large clinical research trials. Donors have turned $200,000 into $4 million. That's a 20 times return on investment. That beats the stock market way, way over. And we fortunately have been able to do that 7 times in the last 12 years in our lab. And so that's donor money to support a coaching program for weight loss, our wellness study that we're recruiting for right now, wellness.org. A smartphone app to help people quit smoking. That's our I Can Quit app. And a chatbot that we're going to be releasing soon for trial, QuitBot for stopping smoking. So whenever I have a new research project idea, it's usually the donor who's come forward and helped start it up. And for them, we are so, so grateful. I did want to add one thought about this confusion over what diet to eat. I'll tell you, in our wellness study, the way we've addressed this issue and Ann McTiernan, who is a collaborator with me in this trial, very grateful to her expertise, is we've taken the approach of helping people reduce the caloric intake with the idea that if you consistently track what you eat, and people are tracking that with a Fitbit app that we give them, you track what you eat, that helps you and then be able to reduce your caloric intake, and that in turn is a very strong predictor of weight loss, which is in turn a strong predictor of cancer prevention. So it's just a different way to kind of take that tack of being less focused on a particular type of diet, more focused on reducing caloric intake, which helps reduce inflammation, which helps reduce weight and curing cancer. So it's a complicated puzzle, but that's how we're addressing that piece of this very complex puzzle.
Jonathan, thank you. And Jonathan, Ann, and Marian, don't go anywhere because we're going to have you back for questions after we do our COVID corner. I'd like to next introduce Dr. Catherine Liu, who I've come to know and respect greatly over the past 2 years. I should also tell people today's the beginning of my 3rd year officially as president of the Hutch. And I got to meet Catherine very early in my time here because of the incredible role she's played in our response to COVID. She's an infectious disease doc who specializes in preventing and treating infectious diseases that affect patients with weakened immune systems. She's head of the Antimicrobial Stewardship Program at the SCCA, and she's working to prevent the emergence and spread of drug-resistant microbes. Catherine, I can't wait till I can have you here and you can actually talk about preventing bacterial infections in immunocompromised patients. Wouldn't that be great and not have to talk about COVID? But you're also an expert in understanding viruses, and you've played such an important role in keeping our patients and our workers safe at the Fred Hutch. So thank you so much for all that you do for our patients and for the people who work here. So first question is, tell us where we are now with Omicron and most importantly with BA.2, which now has me nervous. So should I be nervous? Should I not be nervous about BA.2? Where do we stand?
Yeah, thanks, Tom. It's great to be with everyone today. So, it's been just over 2 months since Omicron was first identified. I mean, it's just incredible how quickly this has spread rapidly throughout the world, has impacted the lives of all of us here on a day-to-day basis. And, I think that we have started, at least our numbers here locally in King County, and I think in other parts of the country, the case counts have started to decline, which I think has been positive news for everybody who, I think for many of us who were watching that curve climb, we had no idea when we were going to peak. And I think we're finally seeing those numbers come down. Though numbers, I think, still continue to remain quite high. And so I think we still continue to encourage people to remain cautious as we kind of learn about this new variant. So it turns out that Omicron is not just a single strain, but there are actually 3 separate sublineages. So I think BA.1 is really the first one that I think came to attention from South Africa. And then BA.2 is the one that has received a lot of attention from the press over the last couple of weeks. There is also a 3rd sublineage that is really making up a very small portion of cases and not really of concern at this point. The BA.2, I think, has gained attention in part because there are some data to suggest that it may be more transmissible than the BA.1. Some countries like Denmark and other parts of Asia, India, have also seen it actually outcompete Omicron as the most dominant strain. We have not yet seen that here in the United States. However, I think one of the features of BA.2 that makes it a little bit more difficult to pick up compared to the original BA.1 is that it is, and it's been known as a stealth variant for this reason, is that it lacks this what's called an S gene target failure, which is what the labs have used as a proxy to identify Omicron. And so it may take a little bit longer for us to identify these because it does require genetic sequencing to identify these particular strains, or this particular strain. I think at this point, I think that the good news is the data seems to suggest that there is no, there does not appear to be increased severity of illness associated with BA.2. And the data, at least preliminary data from UK, suggests that the booster doses offer similar levels of protections against BA.1 and BA.2. I think the bad news is that I think the emergence of BA2 has led some to think that this may lead to a more prolonged sort of wave, that we may not see a sharp decline in cases as we saw in South Africa. So there may be sort of a longer tail of Omicron, and we may be seeing this kind of hover along. We may sort of decline and then plateau a bit before this completely comes down. So I would just prepare for maybe a longer wave than we had initially anticipated based on what we saw out of South Africa.
And so, Catherine, next question for you would be, this morning we heard that Pfizer has applied for EUA for children under 5. Can you give a comment about that, and what's your recommendation about the role of vaccination of the very young children at this point?
Yeah, so I think, certainly I think some exciting news, I think there was that Pfizer has now applied formally for this. I think some of the early data just prior to the new year seemed to suggest that perhaps some of the responses were not as high in I think the 2 to 4 age group, although there was no safety concerns. They were sort of interested in studying sort of a third dose. I think the FDA has encouraged them because of the current state of the pandemic to move forward with applying based on the 2-dose regimen and then sort of await the 3-dose data. We'll have to sort of see what the FDA ends up coming out, what they end up landing on. But I think the hope is to be able to make this vaccine available for our most youngest population, where there certainly has been a tremendous impact. I think, not only have we seen, children being hospitalized for COVID, but also just the disruption for everyone in their daily lives. Many people in this audience may have children, grandchildren in daycare. The impact of COVID, I think, in young children extends beyond, to all, the entire family and household. So I think we're all looking forward to having this available for our younger children.
Thanks, Catherine. And one question before I bring everybody back, which is the one of the things that I think is still somewhat controversial and misunderstood by some people, which is this difference between being boosted and being infected. So we talk about natural immunity. We talk about people who've been vaccinated and then had a course of COVID. Do those people still need to be boosted? Can you comment on the difference between being boosted and actually having an infection with COVID?
Sure. So certainly there is this phenomenon that we're seeing more recently of what's called hybrid immunity, which is basically natural immunity that is, further boosted by vaccination, or it could occur the other way around, where somebody's vaccinated and then develops a breakthrough infection. There are some studies that indicate that those who have had hybrid immunity have, actually may have a significantly more robust response than immunity from a 2-dose vaccine or natural immunity alone. But that said, I would not encourage people to try to get a breakthrough infection to boost their immune response and risk the potential consequences of developing a COVID infection. A vaccine booster is by far, the much, much safer approach. And so we continue to recommend that those who have been vaccinated and subsequently develop a breakthrough infection should still get a booster. I think one of the problems with natural infection is that the immune response that's generated after a natural infection is quite variable. So for example, somebody who has an asymptomatic infection or a mild case of illness may not necessarily have the same immune response as somebody else. So it's very hard to predict, what type of immune response you might get from a natural infection. So a vaccine or a booster basically allows for a standardized dose to be administered to elicit a more reliable immune response. So we would, continue to encourage those, even if you've had a natural infection following vaccination, 2-dose vaccination series, to get that booster dose for that additional level of protection.
Great. Let's bring Catherine. Thank you. There's a couple of questions that have already come in that I think will be for you. Let's bring everybody back and let's answer some of the questions that people have raised in the chat and the Q&A area. So this is a great question that comes in from Leslie Reed, and it affects me as well because I have a personal affinity for sugar, and I know that's not a good thing. But Leslie Reed says, Are there foods that she should try to include or exclude for her diet? And really, what about sugar? Is it as bad as some people say? And let's have Marian and then maybe Ann give us their opinion about foods to avoid or take, and what do they think about sugar?
It's a great question. Thank you, Leslie. I think what we're starting to realize in the nutrition science world is that there's no magical foods. And think about the whole is more than the sum of its parts. So everything you eat, look at your plate, morning, noon, and night. Does it include a variety of foods, colors, so fruits, vegetables, whole grains, lean protein, low-fat dairy? The pattern of what someone eats day in and day out over a period of months and years is more likely going to reduce their cancer risk than just avoiding or including one particular food. And I like to take the positive tack. I think it's more helpful for people to think about what to include rather than a lot of no's. In terms of sugar, the most recent dietary guidelines, which includes evaluation of the types of data that Ann was talking about with regards to physical activity guidelines, we do the same for nutrition every 5 years. It's mandated by the federal government. And about 2 teaspoons of sugar a day for most adults can be included in an overall healthful dietary pattern. So it doesn't mean you have to go 0 sugar, but do keep it moderate because it doesn't provide any nutrition and it can add some extra calories, but it doesn't necessarily mean you have to go 0 sugar. So a couple of teaspoons a day is fine.
And thank you. Ann, do you have any perspective on this?
Well, yeah, for those people who are trying to control their weight, either they gained some weight during the pandemic or they've been doing it all their lives and they want to cut down on their calorie intake, sugar might be one way that you could decrease. But again, as Marian mentioned, maybe you want to do it slowly, replace it with something else rather than just taking it away. But sugar drinks is one way because sugar drinks don't fill you up. They might make you feel happy, but they don't fill you up. And if it's hunger that is driving you to eat more, then maybe turn that hunger towards something that will be filling. So reducing sugared drinks, whether it's a latte or a sugared soda, might help with reducing calorie intake without causing too much pain of hunger.
So next question, I'd like to get all 3 of you to come up with an answer for. So Jonathan, you mentioned the concept of inflammation. This inflammation, how reducing levels of inflammation may help both in terms of cancer recurrence and cancer risk. I'd like you to comment on that. And then Ann, you had a terrific answer in the Q&A area. And I wonder if you could address the issue of inflammation. And then Marian, if you could address this issue of an anti-inflammatory diet. So these are all things I get asked all the time. So we'll start with Jonathan, then Ann, then Marian.
Well, it's just the idea that the inflammation is caused by, you might have like an excess sugar in your diet or excess calories, and it's fat that it comes around the organs of the body can lead to inflammation, which can to lead to proliferation of cancer cells. And then over time, that could increase the risk that you would develop a diagnosable cancer. And so there's been a lot of focus now in basic research to understand the gut microbiome and to understand what is happening in the gut, to understand this inflammatory process as a new path to understand the cancer pathogenesis link between diet and cancer. So I think Marian, or I think of the Joanna Lampe and others, or there's a very strong contingent of dietary researchers in cancer prevention in our program who are really focusing on this very acutely.
Ann?
Yeah, inflammation is one thing that has many different ways of being measured in the body. It can be measured locally in a tissue. It can be measured in the blood. And there are many different ways of looking at it. But when we've done large scale cohort studies following large numbers of people, we can't measure things in tissue too much, but we can measure in blood. And we see that people that have these very high levels of inflammation in their blood, one specific one is C-reactive protein, but it doesn't really matter which one you measure. They all kind of track together. That those people who have high levels of inflammation have increased risk for several cancers. But the good news is that we've shown in our weight loss study that just losing about 10 to 20% of your starting weight, usually just 10%. So if you start at 200 pounds, losing 20 pounds over a year, that reduces the level of inflammation in your blood by up to 40%. That was actually an average, 40%. And you can't get that level of reduction from any medication that I know of. There are some medications that can help, like statins or non-steroidal anti-inflammatory medicines like ibuprofen. But we really saw a really powerful effect of weight loss. And so for those people for weight loss is very difficult, then perhaps at least trying to focus on not gaining weight.
That's terrific. And Marian, I'm going to ask you specific anti-inflammatory foods, the anti-inflammatory diet. I'd love to find it if it's out there.
There are probably half a dozen or more so-called anti-inflammatory diets. A lot of these have been published in what we would call popular books. You can go to Barnes & Noble or the university bookstore and find a book in the cookbook section or in the medical section written by someone about how to reduce your inflammation by eating certain foods or avoiding certain foods. There are also a number of cohort studies and described cohort studies previously where the researchers examine the diets of participants to see if they've eaten certain foods, and then they track that over time with their cancer risk. I think we have a lot to learn in this area. I think it's better if we can try to identify eating patterns that either increase or decrease inflammation, and we've been able to do this in some of our studies here at Fred Hutch. We have a really unique way of being able to do controlled feeding studies in our prevention center here at Fred Hutch, where we bring people in. They can only eat what we give them for defined periods of time. So these are really very tightly controlled experiments. They have to be short-term because they're very expensive, and it's also hard to get compliance when they're long-term. But these short-term studies can be very effective at determining whether or not a certain eating pattern or certain foods might increase or decrease inflammatory factors. And we've, in fact, found that in certain studies that plenty of whole grains in the diet, plenty of fruits and vegetables will tend to decrease some of these inflammatory factors in the blood that Anne was mentioning. But to get back to your main question, I'm not sure we're at the point yet where we can definitively say there is one anti-inflammatory diet, and this should be followed to decrease inflammation, decrease cancer risk. I think we need to have more rigorous research in this area.
Thank you, Marian. And I think one of the points I want to make to the people who are joining us today is how important your support for the Hutch is in this kind of work. I had the pleasure of touring our shared resource that we use for preparing special diets and for exercise in the Arnold building, in the lower level of the Arnold building. It's an incredible resource, supported by, again, people from the Fred Hutch who support the Fred Hutch and our grants, and the ability to give defined diets to people and to help try to figure out the answers to these questions that so many people have is, again, helped by the generosity of this group. I now have a question for Catherine, and then a question for Catherine and the remainder of the group. So Catherine, I just had a discussion with a friend of mine who takes an anti-CD19 molecule for MS, We have another question from someone who takes Enbrel, possibly for rheumatoid arthritis or perhaps another indication. They didn't mention what it is. And they're immunosuppressed from Enbrel or from Rituxan or from these other drugs we're using. You specialize in the care of patients who are immunocompromised. What do you recommend about this group of patients? Meaning they've all been vaccinated, they've all gotten boosters. How should someone who's got MS or got rheumatoid arthritis or has Crohn's disease, one of the frustrations is we have so many drugs now that help these patients, and yet they suppress the immune system. So what are you telling patients who are immunocompromised in terms of how they should approach COVID?
Yeah, thanks, Tom, for that question. So I think, first of all, I think one thing that we have actually noticed is that, some of these patients in our cancer center have not necessarily all gotten their boosters. And just one sort of comment I want to make is that we are sort of considering, so for the immunocompromised individuals, we are recommending 3 doses as their primary series, and then a 4th dose as a booster. In contrast to the current guidelines for an immunocompetent individual, the recommendation is a 2-dose primary series followed by a booster 5 months later. So I think first the key step is we want to make sure that they are getting the 4 doses in terms of vaccine protection. And then there are some additional therapies that are available, although the supply is relatively limited at this point, that can help to further mitigate the risk. There is a monoclonal antibody called Evishield, which is available as pre-exposure prophylaxis. So for somebody who does not yet have COVID, who has not been exposed, this monoclonal antibody has been shown in clinical trials to reduce the risk of developing symptomatic COVID infection by about 80%. This is sort of data from the pre-Omicron era, but does offer another layer of protection, is not meant to be a replacement for vaccine, but meant to supplement that. And again, supply is limited, and so that is part of the challenge at this time. But I think if people are able to access that, I think that would be another way to protect themselves. And then finally, I think in this era where we still are seeing high case rates, I would encourage those who are immunosuppressed to continue to take precautions to limit their exposure. There's nothing that can be sort of 100%. I think the vaccines will help. Evishield can help potentially if you can get it, but continuing to maintain those precautions to limit exposure, and having everyone around you, your caregivers, loved ones, vaccinated as well. I think that's really, really key, is making sure those around you that you spend time with are vaccinated and boosted.
And thank you, Catherine. The next question, I'd like to hear Catherine first, and then Ann and Marian and Jonathan give us some thoughts if you have any. So Catherine, I'm going to ask you the question about COVID that we've been talking about with cancer, which is diet and exercise. So what role does diet and exercise have for people who are getting diagnosed with COVID? Are there things in their diet they should watch? Are there exercise routines that you recommend with your patients who get COVID? What do you recommend in terms of diet and exercise? And then curious what Ann and Marian might think.
Yeah, it's a great question. I think certainly in the early part of illness, people may not be feeling so well. So I think, I would encourage them to do whatever activity they are able to. Many of the infections that we are seeing right now in the setting of Omicron are mild, so people are, able to sort of do some limited activity. Obviously they have COVID, so they're going to be home and sort of, isolating themselves. I would encourage them to continue to eat healthy, as we've heard about throughout the course of this discussion. Just making sure that you're drinking lots of fluids. I think as with any respiratory virus, you just want to stay hydrated, because you can have be losing fluids, insensible fluid losses in the context of just having an infection. So staying hydrated, eating well, and whatever activity you can do, I wouldn't overdo it. I wouldn't push yourself. As you start entering the recovery phase and are able to be out of isolation, I would, start to increase your activity, go outside for walks if you can, and just, again, take it easy initially and not overdo yourself, but continue, exercise as you're able to.
Ann and Marian, anything on diet and exercise and COVID?
Well, I think there are a few things that are relevant. One is what we've heard early on, and it continues to be the case, that people who have obesity or overweight have increased risk of more problems with COVID, either more of the side effects or more severe disease, or even more risk of dying. So that's something in the background always, but it's been true for other infectious diseases as well. So I wasn't surprised to see it with COVID, but it's just really remarkable. In terms of exercise, I think there have been enough cardiovascular problems with COVID for some cases that it might be worthwhile taking it easy, like Catherine mentions. That not to push yourself. This is a time to be kind to yourself, and to realize that maybe getting up and moving might be helpful to keep you going, but it's not the time perhaps to keep up your training if you're really that active. Not the time to take up a training program. It might be the time to make your recovery, and even athletes will do this. If athletes are having a serious injury, they'll cut back. So pretend your body's an athlete and be kind to it.
Marian?
Yeah, I'd like to offer 2 brief points. The first is I'm more concerned about long COVID in terms of diet and physical activity habits than I am about the acute phase. I have family members with long COVID symptoms, so I know the symptoms are very real. This is a very important area of study, and we're going to be looking at this in the Women's Health Initiative. Thanks to Garnet Anderson and a number of other investigators in WHI, we've been able to query thousands of women on whether or not they got COVID, whether they were hospitalized, intubated, and so forth. And we're going to be following this up to really do some in-depth investigation about what are some of the predictors of long COVID, and perhaps does diet or physical activity make a difference. And the other point I want to make, which I imagine some people who are listening today might be wondering about, is vitamin D. You see this a lot in the popular literature, a lot of testimonials about whether or not taking a vitamin D supplement, which has a relationship to immunology, whether that can prevent COVID or whether it can reduce symptoms. I have to say, as of today, as of now, doesn't mean a really good peer-reviewed study won't come out tomorrow, but as of today, we don't have sufficient evidence yet to say that taking a vitamin D supplement will reduce the severity of the disease or prevent the disease. So we do need more research in this area.
And so Jonathan, if you think about everything we've been talking about today, whether we're talking about diet, whether we're talking about smoking, whether we're talking about exercise, we're fundamentally talking about behavior changes and how we do that. Can you tell us a little bit about your work on acceptance and commitment therapy, and what that means and how you think that's going to work to influence behavioral trends?
Absolutely. So acceptance and commitment therapy, it focuses on 2 key things. One is it focuses on what is your North Star? What is the thing that gives you a sense of inspiration and direction in your life? I'm talking about your family, your relationships, your health, your spirituality, your connection to nature. Those are the things that are always with us. Those are the things that can always guide us. Those are the things that always take us forward in a certain direction. And this is especially important now as we're going through this horrible pandemic that's affecting all of us in different ways. And to be able to see beyond the clouds and see beyond the challenges that this pandemic is bringing us is to remember your North Star and to focus on what is it that's guiding me, what fundamentally motivates me as a person and gives me a sense of meaning and purpose in life. We all have a North Star. It's just take a moment, have a picture that represents it, write it down, and look at it every day to remember as we're going through this difficult time to focus on that. The second, which I think pertains to all the questions you've been asking today, is to look inside and to notice what you are experiencing, whether if you're drinking more, if you're not exercising, if you're eating more, if you're feeling fatigued from long COVID. that's an invitation from your body to look inside and to notice and to be aware of what your thoughts are, what your sensations are, what your feelings are. And the reason why we overeat and the reason why we might drink or why we've been smoking more than we have in the last 20 years is because people, when they feel discomfort, we tend to want to avoid discomfort. We tend to want to push it away and get away from it. And so the antidote to that from the acceptance and commitment therapy point of view, also known as ACT, is to be willing, is to be open, is to move toward and to allow these experiences to come and go on their own. I talk about it in more depth in my TED Talk, The Secret to Self-Control, if people are interested. But it's essentially allowing and being willing. And if you can do that, the data has been very compelling for ACT. There have been 800 randomized trials now on a variety of behaviors showing that it predicts less drinking, less smoking, increased exercise, and less eating. So I think it's as appropriate now as it's always been in the past.
Jonathan, thank you. And we have a time for one quick question. This will go to Marian. So many people have asked what I am consuming now. It's not a Budweiser, which could be this color. It is a diet soda. And I'm sorry for drinking that. I tend to like to drink a liquid when I'm doing public speaking. So Marian, just how bad are artificial sugar supplement drinks? I understand they're not great for your diet. And how awful do you think they are? Because that's been asked by the people.
Great question. They don't provide any calories, so if someone needs to reduce weight and cut out calories, that might be something that could be helpful. There was a very interesting paper that came out in Science, maybe about 4 years ago, where they compared the gut microbiome of people who were drinking artificially sweetened beverages to those who were not. And the gut microbiome of those individuals drinking artificially sweetened beverages was different and perhaps not as healthful. Some other recent studies have shown that something that we call metabolomics, which is a way to measure different metabolites in the blood and in the urine, was also different in people who drink artificially sweetened beverages. So this is a very active research area with more data kind of tilting towards it may not be so healthful to consume these artificially sweetened products.
Thank you, Marian, and I stand warned, and I will do my best to reduce my intake of Diet Coke, and we'll work on better drinks at our next session. Catherine and Jonathan, Marian, thank you for a fantastic discussion. Really brought a lot of light to some really challenging topics. I want to thank everyone for joining us today. The support that we receive from our donor community is essential. None of the work that Catherine, Jonathan, Anne or Marian do would happen without you. So thank you very much for supporting us. Thank you for fueling our research. Please consider making a gift to the Fred Hutch, and there's a code you can scan to do that. Please save March 22nd at 9 a.m. for our next Science Says with Trevor Noah, who'll be joining us live. Thanks so much, and have a great afternoon.